Hello, everyone. My name is Renelo Zammit, or Nilo for short. I am a mental health clinician, and I want to thank my fellow professionals and multidisciplinary team members, including our nurses, educators, and social workers, for joining me today. This presentation examines the impacts of childhood trauma, specifically early exposure to family and domestic violence, FDV, through attachment theory. Attachment theory posits that the bonds children form with early caregivers fundamentally shape their lifelong relationship patterns. When a child's secure base is shattered by FDV, the caregiver becomes a source of both fear and comfort. As we will discuss, this disruption often leads to insecure or disorganized attachment styles, ultimately resulting in severe difficulty staying in relationships when they become challenging or too close. Exposure to FDV refers to a child's direct or indirect experience of violence within family or intimate partner relationships. Family violence may occur between parents, siblings, kinship members, carers, or co-residents. While domestic violence occurs between current or former intimate partners, both may include physical, sexual, emotional abuse, coercive control, intimidation, and threats. For children, exposure indicates seeing or hearing violence, living with chronic fear, witnessing controlling behavior, trying to protect a caregiver, seeing injuries or property damage, and experiencing disrupted routines and caregiving. This is developmentally significant because exposure to domestic violence is recognized as a form of child maltreatment associated with increased risk of mental disorders and health risk behaviors. Systematic review evidence also links exposure with anxiety, depression, post-traumatic stress symptoms, aggression, and poorer social and educational functioning. Attachment theory helps explain why FDV is so disruptive. Its key constructs include the caregiver as a secure base, the child's felt safety, proximity seeking, emotion regulation, and internal working models of self and others. In secure attachment, the caregiver is experienced as available and protective, allowing the child to seek comfort, explore safety, and gradually regulate emotions. In FDV, however, the caregiving system can become frightening, inconsistent, or emotionally unavailable. The child may need comfort from a caregiver who is also traumatized, threatened, or associated with danger. Over time, this can contribute to insecure or disorganized attachment strategies in which closeness feels unsafe, unpredictable, or overwhelming, creating later difficulty trusting others and staying in relationships when they become challenging or emotionally close. Attachment theory helps fellow professionals and multidisciplinary team members understand FDV exposure not only as an external traumatic event, but as a relational trauma that can disrupt the child's core attachment system. In attachment theory, the caregiver is ideally the child's secure base, the person who provides safety, comfort, co-regulation, and confidence to explore the world. When FDV occurs, that system can become confused and unsafe. The child may experience the home as unpredictable, the offending caregiver as frightening, and the non-offending caregiver as emotionally unavailable, traumatized, overwhelmed, or unable to fully protect them. This creates a painful contradiction. The child's attachment system pushes them to seek closeness to caregivers, but the violent or fearful environment teaches them that closeness may also be dangerous. This interaction between FDV exposure and attachment constructs can lead to several outcomes. First, the child's felt safety is weakened. Instead of using the caregiver as a reliable, secure base, the child may remain hypervigilant, scanning for danger, changes in tone, conflict, or signs that violence may recur. Second, proximity seeking may become disorganized. Some children may cling, become distressed at separation, or try to protect the caregiver. Others may avoid emotional closeness because they have learned that needing others is unsafe or unreliable. Third, emotion regulation is disrupted. Children usually learn regulation through repeated experiences of being soothed by a responsive adult. However, FDV may expose them to fear without consistent repair, increasing the risk of anxiety, aggression, withdrawal, sleep disturbance, post-traumatic stress symptoms, and social or educational difficulties. Fourth, the child develops internal working models of self and others. A child exposed to FDV may come to believe, I am not safe. Adults cannot protect me. Relationships are dangerous, or I must stay in control to prevent harm. These models can later contribute to difficulty trusting others, managing closeness, and staying in relationships when conflict, dependence, or emotional vulnerability arises. Attachment theory, therefore, explains FTV exposure as a disruption to the child's relational template. The issue is not only that the child has witnessed frightening events, but that these events occur within the relationships that should provide protection. This is why the treatment response must focus on relational safety and emotion regulation rather than solely on symptom reduction. Based on this theorization, child-parent psychotherapy (CPP) is an appropriate intervention. CPP is a relationship-focused, trauma-involved dyadic treatment for young children and caregivers who have experienced trauma, including intimate partner violence. It is especially relevant because it treats a caregiver-child relationship as a main mechanism for restoring the child's safety, attachment, and social-emotional well-being. The first key treatment target is relational safety. Because attachment theory suggests that FDB disrupts the caregiver as a secure base, CCP works to rebuild the child's experience of the non-offending caregiver as safe, productive, protective, and emotionally unavailable. In practice, this means a therapist meets with a caregiver and child together, often through play, observation, and reflective discussion. The clinician helps the caregiver understand the child's behavior as communication rather than naughtiness or defiance. For example, clinginess, aggression, avoidance, or tantrums may be reframed as trauma-based attempts to manage fear. CPP also uses the triangle of explanations to link the child's trauma experience, current feelings and behaviors, and the treatment plan in developmentally appropriate language. This helps the child and caregiver make meaning of what happened without blame, secrecy, or confusion. The second key treatment target is emotion regulation. Because FTV can overwhelm the child's developing stress regulation system, CPP supports the caregiver to become a co-regulator. The therapist may coach the caregiver to notice emotional cues, name feelings, respond calmly, provide predictable routines, and repair moments of rupture. Over time, repeated experiences of being understood and soothed help the child internalize safer expectations of relationships. This can reduce trauma symptoms, improve behavior, and strengthen the child's capacity to tolerate closeness, separation, frustration, and conflict. Importantly, CPP is not couples therapy with a perpetrator where safety is unresolved. For FDV, the priority is safety planning, stabilization, and strengthening the relationship between the child and the non-offending caregiver. For our multidisciplinary team, this means our shared role is to identify FDV exposure early, understand trauma behaviors through an attachment lens, and support referrals into dyadic trauma-informed interventions such as CPP. In summary, attachment theory tells us what has been disrupted: safety, trust, regulation, and internal working models. CPP then tells us what to repair: the caregiver-child relationship as the pathway to recovery. In summary, early exposure to FDV should be understood as both a traumatic and relational experience. It can undermine children's safety, routines, caregiving relationships, and mental health, including increased risk of anxiety, aggression, and post-traumatic stress symptoms. Attachment theory helps explain why. When the caregiver-child relationship becomes associated with fear, inconsistency, or unavailability, the child's secure base, emotion regulation, and internal working models can be disrupted. Child-parent psychotherapy responds directly to this disruption by using the caregiver-child relationship as a pathway to repair, targeting relational safety and co-regulation. For multidisciplinary teams, the key implication is to identify FDV early, view behavior through an attachment and trauma lens, and support dyadic intervention that helps children feel safe, connected, and capable of recovery.